Today we will be discussing the surgical diseases of the pancreas. As you all know, the pancreas is a very important and vital organ that's situated in the retropathogenous space of the upper abdomen. Some very major and serious diseases originate in the pancreas, and these at times pose great challenges to the treating physician and the surgeons.
The pancreas is a very important organ which is situated in the retroperitoneal area of the abdomen. Okay, it looks like a leaf-shaped appearance and consists of a head, body, and a tail. The head fits nicely into the C-shaped part of the duodenum, and the tail abuts onto the lower part of the hilum of the spleen. It consists of two types of cells. The bulk of the gland is formed by cells known as acinar cells. Acinar cells, more than 80% of them will be acinar cells, which are responsible for the secretion of digestive enzymes, amylase, trypsin, and lipase. Scattered among these acinar cells are cells known as islet cells, pancreatic islets, which secrete hormones, and the hormones are mainly insulin and glucagon. These acinar cell secretions drain into ductules, which finally form the main pancreatic duct that runs through the center of the organ. And this pancreatic duct at the lower at its exit joins the common bile duct to form the ampulla of water, which then empties the digestive enzymes into the second part of the duodenum. It's important to understand there are two types of cells, beta cells and alpha cells in the endocrine acinus, which are scattered within the gland. And the upper border of the pancreas is closely related to the splenic artery and vein. As I said, the pancreas consists of exocrine portion, which is the predominant component, and an endocrine portion, which contributes less than 1/4 of the gland. The exocrine portion is responsible for secreting serum amylase, the most widely used blood test for pancreatic damage, serum lipase, and serum trypsin. Lipase for the digestion of fats and trypsin for the digestion of protein. Other enzymes include elastase and chymotrypsin. The endocrine portion, which consists of clusters of islets of Langerhans or pancreatic islets, consists of three types of cells: A cells, alpha cells, which secrete glucagon; B cells or the beta cells secrete insulin; and the D or delta cells secrete somatostatin. The most predominant component is the B cells or the beta cells, which secrete insulin, which reduces the blood sugar. Glucagon increases the blood sugar. Okay, now the exocrine function being the most predominant function of the pancreas, what stimulates its secretion? Okay, what stimulates the pancreatic secretion of these enzymes? Basically, the stimulus comes from two main sources. One is the presence of food in the duodenum, which prompts or stimulates the duodenal mucosal cells to secrete secretin and cholecystokinin, which have a positive influence on the pancreatic secretions. The second stimulus is the vagus nerve, which increases the volume of these secretions from the pancreas. Now, for pancreatic diseases, certain investigations are commonly done, which include the list I listed here: blood tests, especially serum amylase and lipase. Sometimes certain immunoglobulins can be done for immune diseases, immunostimulatory diseases. Urine tests, amylase, trypsinogen 2, and diastase also increase in patients with pancreatic damage. Stool tests, fecal tests, and stool elastase tests are also important to assess the function of the pancreas. Ultrasound abdomen to detect mass lesions, dilated ducts, and pancreatic calcifications. CT scan is a very important diagnostic modality for detecting enlargement of the pancreas, tumors, and acute necrosis. MRCP is another important diagnostic tool, especially it gives a very good imaging of the pancreatic and bile ducts. Endoscopic ultrasound or EUS for close-up view of the lower end of the pancreas, the head of the pancreas and the pancreatic ducts, and even doing endoscopic biopsies of this region. The last one I mentioned here is the pancreatic function test or PFT, which is also known as the secretin simulation test. Okay. I also to mention a few congenital abnormalities that you are expected to know a bit the principles. Ectopic pancreas, cystic fibrosis, which is a common disease in the West, which is rarely seen in our patients. Annular pancreas, where the pancreas splits and surrounds the second part of the duodenum, and sometimes this can cause compression and duodenal obstruction. And congenital cystic disease of the pancreas. Now we come to pancreatitis. Okay, pancreatitis is inflammation of the pancreas. Generally there are two types of pancreatitis, acute and chronic. Acute pancreatitis is an acute onset and severe. It tends to be either mild or severe. Okay, this is due to the severity of the inflammatory process. In mild cases, there's interstitial edema with mild pancreatic dysfunction. And most of the cases, almost 80% of the cases, fall into this category. And the mortality rate from this is low. In severe pancreatitis, where there's severe inflammation, there is severe pancreatic necrosis and massive inflammation. And about 20% of cases fall into this category. And the mortality rate of severe pancreatitis is high, 20 to 50%, depending on the involvement of other organs, which we shall see in a short while. There can be multi-organ failure within the first week, which is very severe, and also there can be secondary septic complications, pancreatic abscess, septicemia, if the patient pulls through into the second week. The second group of inflammatory condition is known as chronic inflammation or chronic pancreatitis. This is due to either a continuation of the acute inflammatory process or recurrent attacks of mild inflammatory processes leading to final chronic inflammatory disease. It is a very irreversible morphological changes that takes place in the pancreas, chronic inflammatory changes. Calcification, fibrosis, and pain and permanent loss of pancreatic function are the ultimate results of chronic pancreatitis, okay, which tend to be very progressive, leading to severe pain, chronic pain, and permanent loss of pancreatic function. Okay, now we'll go into details of acute pancreatitis. Acute pancreatitis is a very, very important condition in surgery. Okay, it's not only important because of the severity of the pain, but also the mortality that is related to severe inflammation. The causes are mainly biliary stones and alcoholism. Okay, biliary stones or gallstones is the major, in our country, is the most common cause of acute pancreatitis. And this is usually due to a passage of a small gallstone through the lower end of the bile duct, resulting in transient obstruction of the pancreatic duct, leading to acute inflammation. Alcoholism is another important cause. It's the second most common cause. About 20 to 25% of cases fall into this category. And others include trauma, such as blunt abdominal trauma, is resulting in injury to the pancreas and the pancreatic ducts. Surgical trauma, especially post-operation in the region of the pancreas, and also post-ERCP, which is becoming an important cause of acute pancreatitis due to the wide use of ERCP these days. Ampullary tumors also can cause peri-ampullary tumors by causing or blocking the pancreatic duct, can lead to acute inflammation and acute pancreatitis. Certain drugs such as steroids, azathioprine, and thiazides are three notable groups of drugs that can cause inflammation. Hypercalcemia, especially in patients with hyperparathyroidism, high level of serum calcium levels can predispose to acute pancreatitis. Then we have infections, especially viral infections. Most important is mumps and Coxsackie B virus infection. And mumps is the common cause of acute pancreatitis, and it occurs in children or young adults. Scorpion bite has been documented as an important cause of severe inflammatory reaction of the pancreas. Malnutrition, annular pancreas, and the other last one is a hereditary due to autoimmune diseases. Okay, and these are usually classified as idiopathic causes. Okay, this is a summary, a pictorial summary of the causes of acute pancreatitis. Heavy alcohol abuse and gallstones, two most common causes. In fact, in our country, gallstone is far more common than alcohol, and 20% of other causes. The other causes include abdominal trauma, certain medications which I should mention just now, infections, especially viral, tumors, genetic or anatomical variants, high cholesterol or triglyceride levels, and high calcium levels. Now we come to the pathogenesis of acute pancreatitis. There are three main enzymes, as you all know, that is mainly coming from the pancreas. The first one is trypsin and chymotrypsin, which are responsible for digestion of proteins. The second enzyme is the amylase, which is predominantly a digestion of carbohydrates, and lipase, which breaks down fats. Okay, so these are the three main enzymes from the pancreas, and they are responsible for digestion of carbohydrates, fats, and proteins. Acute inflammation occurs when there is an abnormal activation of digestive enzymes. Okay, the word is abnormal. Abnormal activation of digestive enzymes within the pancreas. This occurs because of the inappropriate activation of the precursors of these enzymes which are inactive. Okay, and these are known as zymogens or proenzymes. So these zymogens or proenzymes are the precursors of the active enzymes. So these precursors are activated, and this in turn activate the enzymes to active form. Inside the pancreas, the most notable of these precursor enzymes or proenzymes is trypsinogen. Okay, here we have noxious stimuli of various causes. They inappropriately activate the precursor enzymes, pre and proenzymes, trypsinogen, and trypsinogen becomes active trypsin activated to become active trypsin, and this results in auto-digestion of the pancreas. And that is the damage that is done in acute pancreatitis. The most common cause, as I said, is gallstone. Is the cause of acute pancreatitis. This diagram shows you the setup of the biliary tree at the lower end of the biliary tree. The bile duct, common bile duct, and the pancreatic duct join to form the ampulla of water, and that empties into the duodenum. Okay, this is a close-up here, ampulla of water. A stone that passes through this ampulla of water causes a transient blockage of the pancreatic duct, and that triggers an acute inflammatory process. So, in the acute inflammatory process, the main damage is the acinar cells, which are injured, acinar cell injury, which releases activated enzymes. And these cause interstitial edema, proteolysis, fat necrosis, and hemorrhage due to elastase. Okay, what causes this acinar? A number of factors that can be contributed or attributed to the acinar injury. One is direct injury of these acinar cells, such as by alcohol, drugs, trauma, and ischemia. Okay, in patients with generalized ischemia and certain viruses, which I mentioned earlier. Okay, these cause direct injury to the cell, and that releases the activated enzymes. Other causes will be duct obstruction, pancreatic duct obstruction, such as gallstone obstruction and chronic alcoholism, the two most common causes. These will cause inflammation, ischemia, and further injury to the acinar cells. And this acinar cells injury again goes into activate the enzymes. The third mechanism is a defective intracellular transport, such as can be caused by metabolic injury, alcohol, or duct obstruction. Okay, in these conditions, the delivery of proenzymes to the lysozyme compartment is affected, and there's intracellular activation of enzyme leading to acinar cell injury. What are the types of pancreatitis? Generally, clinically, there are two types of pancreatitis. One is known as interstitial, and the other one is necrotizing. Interstitial, in the pancreatitis, there is acute inflammation. Okay, and fortunately, vast majority of patients, 90% of cases, fall into this category, and 20% of them can become more severe. All right, only 20%. Most of them fall into the inflammatory or interstitial list, and this because of the accumulation of fluid due to the inflammation. The patients may lead to the formation of pseudocysts. The mortality rate is about 2%. In the other form of acute pancreatitis is called the necrotizing pancreatitis, where the inflammation proceeds or progresses on to form necrosis of varying severity. Okay, if it's severe necrosis, then the patient becomes severely ill. And about 10% of patients fall into this category. 10% of acute pancreatitis fall into this category, where there's progression of this inflammation to massive necrosis. Usually, moderate or severe pancreatitis is the outcome of this condition. And if it is severe, it may lead to shock and multi-organ failure. Next, we come to the clinical presentation of acute pancreatitis. First, the symptoms. The most predominant or the most prominent symptom of acute pancreatitis is upper abdominal pain. The pain is usually in the upper abdomen, epigastric region, lower epigastric region, around the umbilicus, more to the left. The pain usually radiates to the back. Okay, that means from front to back. Relief by bending forwards or lying in a curled up position, and the abdominal pain feels worse after eating, is precipitated by food or aggravated by food, and there is significant degree of nausea and vomiting and even retching. So vomiting is a very prominent symptom in these patients. So the pain and vomiting are very important abdominal symptoms. Next, the signs can be due to the inflammation. There can be fever, usually tachycardia, dyspnea, jaundice, tenderness, grey turners and Cullen sign, silent abdomen. Silent abdomen, that means on auscultation there are hardly any bowel sounds, and there is also leukocytosis. This tenderness and sometimes there is guarding is maximum around the area of the umbilicus and epigastric region. Okay, in mild acute pancreatitis, the signs may not be very prominent. The patient may look well. He's got mild pain, mild tenderness. Otherwise, he looks quite well, and he may look deceivingly, he may look well. In severe pancreatitis, patient looks very ill, toxic, confused, sometimes can be mildly jaundiced. Usually this tachypneic, tachycardia, hypotension, going into shock. He may be hypothermic or normothermic. Later he develops a fever, and on examination of the abdomen, there is tenderness and muscle guarding in the epigastric region maximum, and it can be over the whole abdomen. Features of generalized peritonitis in severe cases. Ecchymosis at the flanks, known as grey Turner's sign due to bleeding tendency. Ecchymosis around the umbilicus is known as Cullen sign. Abdominal distension from ileus or ascites. Sometimes there can be massive ascites and ileus due to peritonitis. And in severe cases of necrosis, you may feel an epigastric mass. This is a picture showing you the classical picture of a pain in severe acute pancreatitis. So I said the onset is acute, side epigastric or upper abdomen, mostly on the left side. Character is agonizing, very severe pain, agonizing pain, burning, continuous, and most of the time it does not relieve with normal medication. Some people describe it as excruciating pain. Radiation towards the back, chest and lower abdomen sometimes may mimic an aortic aneurysm rupture or a myocardial infarction. An aggravating factor by lying supine position, patient unable to lie in the supine position or refuses to lie down to be examined. And relieving factors sitting up and leaning forward as shown in this picture. Okay, leaning forward to relieve and applying pressure to his upper abdomen to relieve the pain a bit. Here another patient, upper epigastric pain on the left side. Patient bends forward to relieve the pain. Here this patient lies up in a curled up position, applying pressure to release the pain in the epigastric region. And this patient again lying in a curled up position and having severe pain. If they straighten the legs, causes stretching of the peritoneum, and that causes pain. So this is to reflex mechanism to reduce the pain. This is the Cullen sign, ecchymosis around the umbilicus. This is in severe hemorrhagic pancreatitis where there is bleeding into the abdominal tissues. And grey Turner sign, lateral and posterior abdominal wall, bruising also. Okay, around the umbilicus, Cullen sign, bruising around the umbilicus, and Turner sign, side of the abdomen, lateral wall of the abdomen. Here, Turner sign, lateral abdominal wall, lateral and posterior abdominal wall extending into the upper part of the right thigh. Next, we come to the diagnosis of acute pancreatitis. Okay, acute pancreatitis is confirmed by the medical history. The severe pain, location of the pain, that's very, and vomiting is a suggestive. And physical examination give you severe tenderness and guarding. Okay, in the epigastric and paraumbilical areas. And typically a blood test, either serum amylase or lipase, is confirmatory. So diagnosis is not a main problem as long as you think of it and do the blood test. Blood amylase or lipase levels are typically elevated 3 times the normal levels during acute pancreatitis. So in order to say for certainty it's acute pancreatitis, blood serum amylase or lipase should be 3 times its normal values. Hemorrhagic pancreatitis is characterized by bleeding within or around the pancreas and is usually considered a late sequelae of acute pancreatitis, and this produces the Cullen's and Gray Turner signs. So diagnosis, these 3 things are very important. Acute pancreatitis of diagnosis is typical abdominal pain and vomiting. Serum amylase or lipase 3 times is normal limit, and the characteristic CT findings which I will show you in a short while. Now, what are the differential diagnoses of acute pancreatitis? So it's a patient, it's a usually a young patient with severe abdominal pain, acute onset, vomiting, and signs of peritonitis. So these are the common differential diagnoses for this condition. Perforated peptic ulcer, acute cholecystitis, ascending cholangitis, acute appendicitis with perforation, acute intestinal obstruction, acute mesenteric ischemia with gangrene, acute myocardial infarction, and abdominal aortic aneurysm rupture or leaking. Okay, so these are all causes of acute abdomen. Next, we come to the assessment of the patient. One of the conditions that we use, one of the criteria that we use to scoring system that we use to determine the severity is called Ranson score. Ranson score is number of factors or parameters that are taken into consideration during admission and within the first 48 hours in admission. The factors that you take on admission: age more than 55 years old, white cell count more than 16,000 per cubic millimeter, blood glucose more than 11 millimoles per liter with no history of diabetes mellitus, lactate dehydrogenase more than 350 units per liter, and aspartate aminotransferase or AST more than 250 units per liter. Okay, so these are the 5 parameters that you assess during admission. Okay, any of them exceeds these limits are given a point each. Then you observe the patient during the 48 hours with treatment, and then you continue to monitor the patient and the following parameters: and fall in HCT, blood urea nitrogen rise, arterial oxygen saturation decrease, serum calcium or falling serum calcium, base deficit increasing base deficit, and also the fluid sequestration more than 6 liters. So you look for these parameters within the 48 hours. Okay, this is a chart summarizing the thing on admission and in 48 hours. These are the parameters that you look on admission and within the 48 hours. And each of them has got 1 point, a score of 1 point, a total of 11 points. The score of 3 or greater predicts severe acute pancreatitis. Okay, so a score of below 3 is considered mild pancreatitis, and the prognosis is very important. Why is this important? Because on admission, patient may come with mild pancreatitis, but in the ward, it can progress very rapidly into severe pancreatitis and multi-organ failure. So this chart or the scoring system here helps to assess the severity of the pancreatitis. So Ranson score and severity, actually it helps to predict the severity and outcome of acute pancreatitis at 48 hours after onset of illness. Mild pancreatitis, less than 5% mortality with less than 3 risk factors. Severe pancreatitis, 15 to 20% mortality with 3 to 4 risk factors. So as the risk factors increase, the mortality rate also increases to the extent that if there are more than 7 factors, almost the mortality is almost 100%. This table is the revised Atlanta criteria for acute pancreatitis, which I find it easy or convenient classification between mild, moderate, and severe pancreatitis. Okay, with mild pancreatitis, there's no organ failure. There's no local complications such as pancreatic fluid collections, pancreatic necrosis, and there are no systemic complications. And such cases typically resolve within the first week, in a couple of days. Okay, in moderate pancreatitis, there is transient or organ failure, which recovers within 48 hours. So it may go into acute renal failure and within 48 hours recover. They can have no or they have local complications or exacerbation of comorbid diseases. Either one of these. So either this, they go into moderate acute pancreatitis. And in severe pancreatitis, there's persistent organ failure. And the organ failure lasts more than 48 hours or maybe become even permanent, such as known as very severe pancreatitis. So this classification is quite easy to understand. Now, the investigations of acute pancreatitis, which I've already mentioned, serum amylase elevated more than 3 times above normal. Usually it rises within hours of an attack and drops within the first week, with a couple of days. Serum lipase, the half-life is longer, so its elevation in the blood lasts longer than the serum amylase. So it is more reliable if the patient comes to you after 1 or 2 days after the acute attack. Urine diastase is another important test in the urine for the diastase. The pancreatic damage, there's increase in urine diastase. Next we come to the imaging in acute pancreatitis. Plain X-ray and chest X-ray are important, which can detect local ileus, sentinel loop, okay, or colon cutoff sign, renal halo sign. These are all important radiological signs. And X-ray may show the presence of a gallstone. Chest X-ray especially is very important to diagnose free air under the diaphragm, because perforated peptic ulcer is a common differential diagnosis. And also X-rays will be able to detect effusion, pleural effusion, and diffuse interstitial shadows. Okay, so these are the role of plain X-ray abdomen. Ultrasound scan of the abdomen is a very important initial investigation aimed mainly to detect gallstone. And then contrast enhanced CT scan is also very important for severe cases, especially to look for necrosis, enlarged pancreas, necrosis, or formation of an abscess. MRI scans may be used in the initial stages when the patient are not fit. So you can, for other interventional procedures, so you can do MRI to detect the bile duct stones, the cause of pancreatic duct, situation of the pancreatic duct. And the last one I told you is the EUS, endoscopic ultrasound, which gives us a closer imaging of the CVD and the pancreatic ducts. Okay, this is a CT scan showing you a massively enlarged pancreas. This is the tail, this is the head, severe necrosis. Okay, this is a severe acute pancreatitis. Okay, this is a cutoff sign. It shows a localized ileus and distension of the transverse colon due to ileus of this area due to the underlying acute inflammation of the pancreas. Inflammatory exudate in pancreatitis extends into this phrenicocholic ligament. Okay, phrenicocholic ligament, and that holds up this intraperitoneal part as a dilated loop. This is abdominal ultrasound. Okay, abdominal ultrasound of this thing, and this shows you the enlarged pancreas here. Okay, enlarged pancreas, and in the middle runs the pancreatic duct, which is also dilated. Okay, the red arrow shows here. Here again, a huge pancreas. Okay, this is a huge pancreas. It's dilated, and there's some fluid there. This is a EUS, endoscopic ultrasound, which clearly shows a stone in the lower end of the CVD or ampulla of Walter, which is clearly causing obstruction of the pancreatic ducts. Another one, stone in the CVD. Okay. So these are the different CT scans of a normal pancreas. Okay. Normally you can see here, this is a normal pancreas, tail, body, and the head here. This is acute pancreatitis, gallbladder pancreas diffusely swollen. Okay, and this is a pseudocyst that is found in an inflamed pancreas. Acute pancreatitis complicating the pseudocyst. Okay, this is a normal I showed you just now, and this is the CT scan showing a massive necrosis in the head and body of the pancreas. Okay, what are the systemic complications of acute pancreatitis? Okay, which are more common in the first week of severe pancreatitis. So I told you systemic complications usually occur in severe pancreatitis and usually occurs within a couple of days, within the first week. Cardiovascular complications can be hypovolemic shock, arrhythmias, pulmonary complications, atelectasis, pleural effusion, and pneumonia. And some patients can end up with ARDS, acute respiratory distress syndrome. Renal complications is a very common systemic complication. Acute renal failure due to severe intravascular volume depletion or acute tubular necrosis. Less common systemic complications are hematological, DIVC, disseminated intravascular coagulation leading to bleeding tendency. Metabolic complications, hypocalcemia, hyperglycemia, and hyperlipidemia. Gastrointestinal complication, paralytic ileus, stress ulceration and bleeding, and neurological, visual disturbances, patient becomes confused, irritable, or even go into encephalopathy and coma. Local complications are more common than systemic complications. Local complications include, and these usually develop after the first week. Okay, and these usually include acute fluid collection. Okay, this occurs in early and still defined wall and around the pancreas. And later it can form a pseudocyst of the pancreas, which is a very common complication of acute pancreatitis. Pancreatic necrosis, initially sterile, sterile. Later it becomes secondarily infected, causing it to become a pancreatic abscess. Usually, this may need a percutaneous aspiration or open necrosectomy and tube drainage for infected necrosis. Pancreatic abscess, when it is secondarily infected with bacteria. Pancreatic ascites, which may need peritoniosynthesis. Hemorrhage into the gut, retroperitoneum or peritoneal cavity in severe hemorrhagic pancreatitis, and portal vein or splenic vein thrombosis. Okay, this is a CT scan showing you massive necrosis of the pancreas, body and tail of the pancreas. Here, this is a pseudocyst, when the collection later becomes well encysted, and that's known as a pseudocyst. Here is a pseudocyst, when the wall of the cyst is formed by the surrounding tissues. That is called a pseudocyst. Okay, massive necrosis, and here necrosis secondarily infected bacteria and forms a pancreatic abscess. Next we come to the treatment of acute pancreatitis. Fluids, very important. Adequate early fluid resuscitation, especially within the 24 hours, first 24 hours, is utmost importance. I must stress to you. Patient is usually very dehydrated, and so you must give adequate fluids. Nutritional support, enteral or parenteral feeding may need to be given. Patient unable to eat because of severe ileus and vomiting. Pain control, usually they need opiates, morphine and other opiates. Treatment of underlying cause, which if other organs are involved, then you give supportive treatment. It's a multidisciplinary management. Acute renal failure may need hemolysis. Multi-organ failures, and the gallstone must be treated, removal of the gallstone. Drugs, somatostatin, which decreases the secretion of the pancreas. Okay, nowadays you have the synthetic versions known as the octreotide. Patients may need PPI to prevent stress ulceration, and if infected, need severe high dose of antibiotics. Most of these patients need intensive monitoring in HDU or ICU. And definitive treatment is endoscopic retrograde cholangiopancreatography or ERCP with sphincterectomy to remove the stone at the lower end of the CBD or ampullary stones. So I must stress, general and resuscitative measures are very important initially, followed by definitive treatment. And then coming to specific treatment of acute pancreatitis, urgent endoscopic with retrograde cholangiopancreatogram, ERCP with sphincterotomy. This is the definitive surgery of acute pancreatitis, to remove the biliary stone or drain the bile duct, and this can either be done by ERCP and followed by laparoscopy and cholecystectomy to remove the gallstones. Surgery for local complications, definitive surgery. Initially, if the patient is you give, subject the patient to aggressive resuscitative and supportive to stabilize the patient, early ERCP and sphincterotomy, followed by laparoscopic cholecystectomy to remove the gallstones. For complications, drainage of the pseudocyst, known as Cystgastrostomy, which can be done either endoscopically or laparoscopically. Necrosectomy, removal of necrotic tissue, desloughing of the necrotic pancreas, and there's abscess, drainage of abscess. So these procedures all can be done through endoscope, laparoscope, or open surgery. short reminder about the pancreatic pseudocyst, which is a collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue, and is usually surrounding the pancreas, which is acutely inflamed. Occurs 4 weeks or more after acute pancreatitis. Can also occur after chronic pancreatitis or after pancreatic trauma. Okay. Clinical presentation: non-mobile, non-tender epigastric mass. The complications of pancreatic pseudocyst: infection, abscess formation, and septicemia, rupture into the gut, compression of the biliary tree with causing obstructive jaundice, can cause bowel obstruction, sudden pain from hemorrhage into the pseudocyst. The treatment of pseudocyst is by percutaneous transgastric gastrocystectomy, endoscopic drainage through stomach, or open gastrocystectomy. The idea of this treatment is to drain the cyst into the stomach, okay, either percutaneously, endoscopically, or through open method. Okay, this is how it's done. This is the stomach. This is the anterior wall is opened up. Inside is the posterior wall, and the yellowish color at the back is the cyst, contents of the pseudocyst. So what you do is you open the wall in the posterior wall of the stomach and create a fistula. Cystgastrostomy. So the contents of the fistula drains into the stomach, and then when the pressure becomes negative, this will seal by itself. So this is known as a open cystgastrostomy or cystogastrostomy. Okay, this is the logarithm for the management of acute abdomen, especially in a patient with acute pancreatitis. So when a patient comes with severe abdominal pain and clinical enzyme CT scan confirm acute pancreatitis. It can be mild, moderate, or severe. Classify the patient. Mild patients, observe the patient in ICU, aggressive resuscitation with fluids, analgesics, nutrition, and maybe drugs and antibiotics. If the patient improves, subject him to an early ERCP and laparoscopic cholecystectomy. If it's moderate, then also with local complications, again he needs surgery, cystogastrostomy, necrosectomy, and abscess drainage. In severe cases where he has got multiple organ failure, mainly ICU and supportive treatment. And when the patient recovers, then you go for laparoscopy or ERCP cholecystectomy. Next we come to chronic pancreatitis. Chronic pancreatitis, as the name suggests, is recurrent attacks of acute pancreatitis leading to chronicity of inflammation. Usually they present with severe chronic pain, exocrine and endocrine insufficiency, okay, pancreatic insufficiency. Males to female ratio is 4:1 and mainly affects males above 40 years of old age. Causes, two main causes. Chronic alcoholism is the most common cause, and pancreatic obstruction from various causes, strictures, tumors, or chronic fibrosis. Okay, these are the common causes. Other causes include carcinoma of the pancreas, basically due to obstruction of the pancreatic duct, pancreas divisum or annular pancreas, hereditary pancreatitis, which is got a family history of chronic pancreatitis, cystic fibrosis, malnutrition, autoimmune pancreatitis, hyperlipidemia, and hypercalcemia, usually in hyperparathyroidism. The clinical presentation of chronic pancreatitis is recurrent severe episodes of dull gnawing epigastric pain, and also the subcostal pain, epigastric and subcostal pain. More to the left side, occasionally the pain radiates to the back or to the left shoulder. Usually these attacks are associated with nausea, vomiting, weight loss, and patient becomes chronically inability to work. Because of the pain, he becomes addicted to analgesic abuse, especially narcotic analgesics, dependence, steatorrhea, stools contain a lot of undigested fat, and malabsorption. In late cases, patient can also develop diabetes mellitus due to destruction of the islet cells. So, in the pathology of chronic pancreatitis, the gland pancreas is enlarged, hard and fibrotic pancreas, strictured and dilated ducts with calcified stones. Okay, there are numerous dilated ducts like a beaded appearance with calcified stones within these ducts. Ducts are occluded with inflammatory cysts that are seen scattered all over. Okay. These are some of the investigations. Chronic pancreatitis. Serum amylase may be elevated in early stages, but later, as the gland becomes destroyed, amylase becomes normal. Plain X-ray abdomen may be able to show you pancreatic calcifications. Then the CT scan will show dilated pancreatic ducts. Here, can you see here? Dilated pancreatic ducts with calcification. ERCP shows you the same, multiple areas of strictured pancreatic ducts with circulations, and these are known as chain of legs or beaded appearance. This is a plain X-ray of the abdomen showing you the calcification. Okay, massive or dense calcification in the region of the pancreas. Patient with symptoms and signs suggestive of chronic pancreatitis, and with the X-ray finding of this, is more or less diagnostic of chronic pancreatitis. Treatment for chronic pancreatitis, mostly medical. Control of pain, very important. I say patient become addicted to analgesics. Improve digestion, giving supplements, because the pancreas is not able to produce enough of enzymes to digest. So these enzymes, a lot of enzyme preparations are available, which patient has to take before meals. And also control of diabetes. Interventional treatment is to relieve obstruction of the pancreatic duct. If all means of relieving pain fails, then you may have to resort to relieve the obstruction of the pancreatic duct. Then you must need to treat the complications such as pseudocysts or abscesses that may develop, fistula, ascites, varices. And this relief of obstruction can be done through endoscopic procedures, ARCP, by doing a sphincterotomy and placement of stents across the strictures in the pancreatic duct, drainage of pseudocysts through pseudocysts through the ARCP, and lastly surgery to remove any mass lesion that may cause obstruction, to remove such obstruction. And these are the few surgical treatments that are available. Pancreatoduodenectomy, okay, duodenum preserving resection of the benign mass lesion of the pancreatic head, and pancreaticoduodenectomy, also known as Whipple's operation. Okay, so the head of the pancreas is removed with the pancreatic duct, and then this is joined to the jejunum. Or you can do a longitudinal pancreatojejunostomy Okay, the duct is open up and you bring a loop of jejunum and anastomose to it. Pancreatojejunostomy. Or you can do a total pancreatectomy. Okay, and that's a very major operation. So this is only reserved for patients who are unable in severe pain as a last resort. Next, we come to the important topic of carcinoma of the pancreas. Okay, carcinoma of the pancreas, there are four main types. The most common is the ductal adenocarcinoma, which which comprises 85% of all malignancies of the pancreas or tumors of the pancreas. It occurs mainly in the head of the pancreas. Pathologically, it is a solid with fibrosis and serous type of lesion. It is difficult often to differentiate clinically from chronic pancreatitis. Often, needle biopsies are needed to confirm the diagnosis, which are these days much easier done by using the EUS, endoscopic ultrasonic methods. It's a precursor. The precursor of such tumors is the pancreatic intraepithelial neoplasia, or PAN-IN, which is a form of carcinoma in situ, which predisposes to the development of frank carcinoma of the pancreas. Carcinoma of the pancreas tend to infiltrate locally along the nerve sheaths via lymphatics and blood vessels. Liver and peritoneal metastases are also common. Serous cystadenoma is another important group of diseases, benign disease, which is on and off can occur in the pancreas, and usually they are benign, but they can grow big size and cause pressure symptoms. Whereas mucinous cystadenoma have a malignant potential. On the long run, they can become malignant. Endocrine tumors of the pancreas are relatively rare, as there's a lot of endocrine cells and tissues in the pancreas. These tumors do occur from time to time. What are the risk factors for carcinoma of the pancreas? Age is a very important factor. Usually occurs in elderly people above 65 years of age. Males are more common. Cigarette or tobacco smoking is a predisposing factor. Family history, higher family history in such cases. Hereditary pancreatitis, chronic pancreatitis also in the long term predisposes to cancer of the pancreas. Hereditary non-polyposis colorectal cancer, ataxia ataxic telangiectasia, Peutz-Jeghers syndrome, familial adenomatous polyp, and diabetes mellitus. Okay, these are some of the risk factors for the development of pancreatic cancer. Now, what is the clinical presentation of carcinoma of the pancreas? Again, this depends on the site of the tumor. The most common site, as I said, is the pancreatic head and the ampullary region. Okay, in this diagram, this is the region, the periampullary region and the pancreatic head. Okay, normally these patients present with jaundice, and classically it's painless jaundice, painless obstructive jaundice. They develop severe pruritus, itchiness, dark urine due to the presence of high amount of conjugated bilirubin in the urine, pale stools due to lack of stercobilinogen, and steatorrhea, malabsorption of fats. Later they develop nausea, epigastric pain, and even an epigastric mass, weight loss becomes a very important feature of carcinoma head of the pancreas, and hepatomegaly with enlarged or palpable gallbladder. This is in keeping with the Courvoisier's law, which states that in case of obstructive jaundice, enlarged gallbladder, obstruction is not due to stones, most likely due to carcinoma. The carcinoma of the head of the pancreas is one of the more common causes of such findings. Next, carcinoma head of located on the body or tail of the pancreas. These do not present very easily. They present very vague symptoms, vague discomfort, anorexia, weight loss, chronic back pain, epigastric discomfort with recent onset of diabetes mellitus in patients over 40 years of age, unexplained pancreatitis, patient develops pancreatitis, there's no gallstone, there's no alcoholic intake, and there's no predisposing factors in this patient, then you have to think of carcinoma of the body or tail of pancreas. Advanced case with enlarged workout nodes, ascites, abdominal and pelvic metastases. That means there are evidence of metastasis, but the primary is unable to be detected on clinical grounds. So an important fact that you must remember is unexplained weight loss. In elderly patients, you must always, one of the factors or of the causes must be included is carcinoma pancreas, especially body or tail of the pancreas, which may not produce clinical obstructive jaundice. The investigation for carcinoma of the pancreas is as follows. If the patient is obstructive jaundice, then urine and blood tests should be done to confirm. You must do a prothrombin time and the CA 19-9. Prothrombin time is important in patients with carcinoma of pancreas with obstructive jaundice because it is commonly prolonged in obstructive jaundice, and this can predispose to bleeding tendency, especially when surgical procedures are concerned. Ultrasound scan of the abdomen will be able to reveal a dilated biliary tree and even the possible cause of the obstruction, which is in not many cases. Contrast enhanced CT scan, CECT, is the best method of examining or best method of investigation to detect carcinoma of the pancreas, head as well as the body and tail. It also can be used to stage the disease and decide on the resectability of the tumor. Okay. If the tumor is seen on CT scan and resectable, then on ultrasound, then you proceed to surgery without undertaking further invasive investigations. Okay. However, if the tumor is unresectable on CT scan or clinically, then ERCP with biliary stenting is the best option for the patient. If, on the other hand, no tumor is seen, then the patient would need a ERCP with brush cytology and or biopsy if it is an ampullary tumor. These days, transduodenal or transgastric FNAC under EUS guidance has become the diagnostic method of choice, where you can have a closer view of the lower end of the pancreatic duct as well as the head of the pancreas and do a transduodenal biopsy of this area to confirm whether it is confirm the cancer and also the nature of the cancer. Next we come to the pancreatic cancer staging. Pancreatic cancer, the T staging. T staging, TNM staging. The T staging is T1 and 2 limited to within the pancreas. Okay, within the tissues of the pancreas. T1 tumor size less than 2 centimeters and T2 more than 2 centimeters. T3 when the tumor infiltrates into the duodenum or infiltrates into the spleen. Okay. Infiltration into the kidney is also considered as T3, the hilum or part of the kidney, and infiltration into the splenic vein also considered as T3. So T3 is local adjacent infiltration of the tumor into the adjacent organs, the spleen, duodenum, kidney, and the splenic vein. Okay, now we come to the resectability criteria for cancer of the pancreas. Okay, you can classically stage them to 1, 2, 3, and 4. In stage 1 is resectable. The tumor is T1 or T2 within the pancreas, no lymph nodes, no metastasis. So in these cases, there's no extrahepatic disease, extra pancreatic disease, and there's no encasement of the celiac axis or SMA by tumor. So this is clearly resectable and major surgery can be undertaken. In stage 4 on the other end is unresectable, clearly unresectable. Tumor any size, nodal status any status, the second metastasis is positive. Therefore, with liver, peritoneal and lung metastasis or metastasis elsewhere, it is clearly unresectable. Now, in stage 2 is considered typically resectable. So in these patients, the regional lymph nodes may be involved, but there's no encasement of the celiac axis or SMA, and there's no possible extra pancreatic. If there's no possibility of extra pancreatic involvement, then it is resectable. Whereas in stage 3, where the tumor is T4 and maybe negative nodal status or N1 and metastasis is negative. Therefore, regional lymph nodes may be involved and there's encasement of the celiac axis or SMA. As a result, it is unresectable. So in all these cases, the special feature of pancreatic cancer is the encasement of the celiac axis or SMA. Becomes a very important deciding factor on resectability of the tumor, besides distant metastasis. Now we come to the management of pancreatic cancer. 85% of pancreatic carcinoma are unresectable at the time of diagnosis. If resectable, the primary surgery for carcinoma of the head of pancreas is known as a pylorus preserving pancreatoduodenectomy, PPPD, with local lymphadenectomy. Okay, so you do a pylorus preserving pancreatoduodenectomy with local lymphadenectomy, or a Whipple's operation where there's removal of the gastric antrum together with pancreaticoduodenectomy. So this will cause more problems compared to that, but it's a more major operation compared to the PPPD, which is a bit more conservative approach, where the pylorus is left intact. This operation for tumors of the body or tail of the pancreas is a distal pancreatectomy. Okay, this is pancreatoduodenectomy, which is Whipple's procedure. The part of the stomach, the antrum and the pylorus, the duodenum, whole of the duodenum, all the four parts of the duodenum with the head of the pancreas is removed. And then reconstruction is done by a triple bypass, choledochojejunectomy. Okay, choledochojejunectomy, jejunum with the common hepatic duct. Then the second one is the pancreaticojejunectomy. Okay, pancreas, resected part of the pancreas, anastomosed with the side of the jejunum. And the third one is your gastrojejunectomy. The stomach is anastomosed to the jejunum. So the jejunum is involved in a triple bypass with the common hepatic duct, with the pancreas and the stomach. In the pylorus preserving pancreatoduodenectomy, PPPD, okay, the difference is you remove the duodenum plus the head of the pancreas. Only difference is the stomach is left behind. Okay, so in the here you see the stomach is left behind, so the pylorus is intact. The pylorus is left behind, therefore there is no regurgitation, reflux. Okay, the triple bypass is still there. Okay, choledochojejunectomy, duodenojejunectomy, and pancreaticojejunectomy. There's no gastrojejunectomy, is replaced with the end to side duodenojejunectomy. Now we come to the prognosis of carcinoma of the pancreas. Okay, so I said 85% of the tumors are not resectable. Only 15% are resectable at the time of presentation. And let's say we take these patients with resectable tumors. You subject them to a PPPD or a Whipple's operation. The post-op mortality, operative mortality, is around 30 to 40%. So 1/3 of them develop some form of morbidity, such as bleeding, infection, leakage from the anastomosis, especially between the pancreas and the bowel, the pancreaticojejunectomy. So the immediate post-op mortality from these complications is 3 to 5%, which is significant. The overall 5-year survival rate in these patients after the major operation is 7 to 25%. Okay, in fact, in most centers it will be more towards the 7. Post-resected mean survival for these patients is 10 to 20 months. Whereas in the 85% of the patients who have unresectable tumor, the locally advanced and tumors or metastatic, the mean survival is 6 to 10% with conservative treatment. And if they have metastatic disease, it is shorter still, 2 to 6 months. So, is it wise to carry on with the major operation, such major operation for the patients with pancreatic cancer, which are deemed resectable? In patients with ampullary tumors, which nowadays we can do a EUS biopsy, you can differentiate between pancreatic and ampullary tumors. The 5-year survival rate after operation is 40%, which is much higher than this figure here, 7%. So it may be advisable to carry with major operation if the tumor is ampullary tumor. So this is the advantage of the latest diagnostic technique with EUS, differentiating pancreatic tumors from ampullary tumors. Then come to adjuvant therapy, chemotherapy for carcinoma of the pancreas, palliative with 5-fluorouracil or gemcitabine, lymphoma, tumors with lymphomatous tumors of the pancreas, which are rare. Less than 3% of pancreatic carcinomas. For them, the treatment with chemotherapy is useful, beneficial. Palliative treatment for unresectable tumors. Okay, the 85% of unresectable tumors. So during laparotomy, if the CVD is obstructed, you can do a choledochoduodenostomy, bypass surgery, or choledochoduodenostomy and cholecystostomie. These are the three bypass procedures you can do if the CVD is obstructed. To relieve the obstructive jaundice, you can do these bypass procedures. Okay, bypass the bile duct to the jejunum. If the patient develops obstruction, if there is obstruction of the duodenum due to infiltration of the tumor, then we do another bypass called a gastrojejunostomy, where you bypass the jejunum to the stomach. Therefore, the duodenal obstruction is bypassed. Patients with massive steatoria can treat them with enzyme supplementation, which I mentioned earlier. Patients with diabetes must be treated. Most probably, they will need insulin. And patient with pain, which is a significant symptom in advanced cases, will need adequate analgesia or even splanchnic nerve blocks. Okay, and need the referral to pain centers. Okay, if you detect during the imaging phase, if you have detected irresectable, then what you can do is place stents either through endoscope or percutaneously. Okay, the two important obstructions are bile duct obstruction and duodenal obstruction. Bile duct obstruction being more common. Bile duct obstruction can be bypassed using a stent percutaneously through the liver and putting the stent into the bile duct and pushing it right into the duodenum. Okay, this is done under fluoroscopy method. Nowadays, with the use of the endoscope, which is much more easier, where you can directly you pass a stent through the ampulla. Okay, through the papilla, pass the stent upwards. You use the expandable stent, and then it can be left in place. It expands and drains the bile. So this is through endoscopy. Or you can use a endoscope to pass a stent to stent the duodenum for duodenal obstruction by the tumor. Okay, the stents nowadays can be very expandable, metal or mesh. Okay, which can expandable and can last for a long time without getting blocked. Summary of the surgical procedures that are available. Resectable. If it is resectable, then we do Whipple's operation, or PPPE, pylorus preserving pancreatic duodenectomy, which is a improvement of the Whipple's operation. If it is unresectable, CVD obstruction, ERCP stenting. Or you can do a bypass, choledochoduodenostomy, or choledochojejunostomy, cholecystostomie. All these are simple procedures which can be done with good palliative results. If duodenal obstruction, endoscopic stenting is the best, is the method of choice. If this fails, then gastrojejunostomy is a better bypass procedure.
This concludes my talk on diseases of the pancreas. I hope to see you again in another session in the near future. Thank you.